Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor. Hi, everybody. Welcome to the Low Carb MD podcast. We have another episode of Journal Club where we are joined by the esteemed Dr. Matt Calkins, and we are going to be talking today about DIETFITS.
DIETFITS.
And the DIETFITS reanalysis. Just so everybody knows what DIETFITS is, let's give everybody a backstory. So let's start about 15 years ago, 20 years ago, where a Stanford researcher by the name of Christopher Gardner, who is now the lead of the Dietary Guidelines Committee, decided to do two major trials. The first trial was the A to Z trial, was a head-to-head trial. This is back in 2007 or 2005, I believe. The A to Z trial was probably one of his most notable trials, where he compared Atkins to Zone to Ornish, and I think the other one was, there was one other trial arm there, but he did a head-to-head trial to try to determine who should win the diet wars. And this is back in 2007. And what he found was Atkins just demolished everybody else. And this was published in the New England Journal. I believe it was a 6-month study. And at 3 and 6 months, low carb had done better. Atkins had done better. And so we thought everything was over. And we thought it was all done. And then subsequently, many trials had come out supporting low carb trials. But in the in sort of the late 2000s, a group of scientists, journalists, Gary Taubes and Peter Attia, started to raise money to further low carb research, and they raised, I think, about a couple $1 million to progress funding. And their objective was to get the most staunch critics of low carb and get them to show that low carb was superior. And one of those, there was 3 major trials that NUSI supported. One was with David Ludwig, which showed that low carb diets increase energy expenditure. Maybe potentially they make people feel good and move more. Maybe they increase metabolism. We're not really sure. The second trial was from Kevin Hall. That was a negative trial. And the third trial was DIETFITS, which is the trial we're going to be discussing today. So Christopher Gardner was the lead author and clinical trialist for DIETFITS. And we discussed, if you're just listening to this podcast, go back and listen to Dr. Matt Calkins's reevaluation of the Keto Med study, which was his latest study in 2022. DIETFITS was from 2018. Anyway, we talk about the bias in that study, and today we're going to be talking about DIETFITS, and we're going to critically appraise DIETFITS in all of its glory. So, Dr. Matt Calkins, did I do justice to the discussion of Dr. Chris Gardner, who was recently appointed to the head of the Dietary Guidelines Committee?
Could not have said it better myself, Tro. I'll say Keto Med, it was kind of a slap in the face. This is more or less like more of a nudge. So I think that he was probably we'll go through the data, but I think Keto Med was definitely a little bit more, how do you say, forward.
You be political. I'll tell the truth.
Okay, yeah, exactly. I'll show people the slides, and then we can chat on each of the slides.
Just finish residency, okay, did everything to okay, and then we'll
exactly.
Yeah,
I got 3 more months here, so
yeah,
ready to get started?
Yeah, let's go.
Perfect. So exactly like Tro said, we're going to be going over the DIETFITS trial, the reason for why this trial even exists, and then we'll be looking at the conclusions plus the reanalysis by Dr. Adrian Sotomoda, along with some of the other colleagues we have in this space. And this was published in 2018 in JAMA. So this was about a 5-year-old study at this point. So why do this study? Exactly like what Tro said, and we'll go over a little bit of the A to Z trial on the next slide. There have been observational data, but also some sub-analysis of randomized controlled trials that showed that some people do better on a low-carb diet and some do better on a low-fat diet, depending on their genetics. There's also this question of, in the A to Z trial specifically, some people that are more insulin sensitive do better on the low-carb diet, or if they're insulin resistant, they do better on a low-carb diet than a low-fat diet. So this actual study, that is what this study wanted to investigate. It was not a true low-carb versus low-fat diet, and to call it as such is a little bit not entirely correct. But of course, the media ran with this once the results came out, and we'll go over that too. So this was a subgroup analysis of the A to Z trial that Tro was just talking about. And essentially what this slide is showing is that when they look at people who are insulin resistant and insulin sensitive, if you just look on the right side of this graph, and I'll explain this for the listeners who are not watching, you basically have no difference between adherence to a low carb diet if you are insulin resistant or insulin sensitive. Now you look on the left side of this graph to the low fat diet. When you're insulin sensitive, you are just as likely to stick to a low fat diet as you are to a low carb diet, but these black bars are shortened for insulin resistance, meaning that when you are insulin resistant, you are not as likely to adhere to a low fat diet. Whereas if you're insulin resistant, you are likely to adhere to a low carb diet. And that's what they said in their conclusion for this paper. Insulin resistant participants were less likely to adhere and lose weight on a low fat diet compared to insulin sensitive participants assigned to the same diet. Does that make sense, Tro?
Makes a lot of sense. I want to take this time to say, if you're listening to this podcast on Spotify, if you're listening on iTunes, Apple Podcasts, and you want to actually join us, you can go to YouTube and watch these slides. Dr. Matt Calkins and Dr. Laura Buchanan have actually put these slides, put a lot of effort into making these slides, informational and useful. And so if you're listening to this podcast and you want to go that extra step, actually go over to YouTube, go to Low Carb MD podcast, and you'll find we have all the slides there. So, yep, let's keep going, Doctor.
Yeah, it can be tricky. So it's always good to just follow along those slides so you can see the data yourself in the graphs. All right, so the methods of this paper now that we're going to go over. So single site, non-crossover RCT. If you remember, our journal club for the Keto Med was crossover, which has its own limitations, I'll say, especially with no washout period. But this was no crossover. So they assigned people to either a low fat diet or a low carb diet. This, and we're going to get into this, this is a huge and absolutely massive nutritional study with 609 participants and 481 people completed it. For reference, Keto Med had 33 completers. Keto Med was also done during COVID, so there was like 10 dropouts from that, but still, this is an order of magnitude greater study than Keto Med. This was a 12-month intervention, and the main intervention that both groups got was just 22 class-based nutritional interventions that were more intensive at the beginning of the intervention. So they had weekly classes for 8 weeks. And then they had, by the end, every 4-week classes for 5 classes total. Does that make sense?
Yeah, it makes a lot of sense. And maybe we can go into, I'm sure you're going to go into the message they actually got.
Ooh, you're exactly right. So that's the last little bullet point here is low carb versus low fat ? So you have to dive into the supplement in order to figure out exactly what they told subjects. And this is why, just to reiterate this multiple times throughout this journal club, this is not a low carb versus low fat head-to-head trial. So their dietary strategy for both of these arms was what they called limbo, titrate, and quality. So first is limbo. They wanted participants to have no more than 20 grams of fat or carbohydrate per day, which makes sense. I agree with that. And that would be a true very low carb diet versus a true very low fat diet. But they told subjects that first, the rate of restriction was not critical to the study, and that reaching 20 grams per day in 2 versus 4 versus 6 versus 8 weeks was not considered to carry any advantage or disadvantage. So just putting this into real life, because I think people will read this study and think about real life scenarios. Do you ever have a patient come in where you say, we want to go low carb, you have prediabetes, we have diabetes, we want to get you off your insulin, but we're going to slowly decrease your carbohydrates over the course of 12 weeks?
I mean, I'm going to tell you, this is not the message they get in our clinic.
Yeah.
In fact, it's quite the opposite. It's how can we help you, reduce your carbohydrates so your blood sugars, are improved right now.
Yeah.
Right. It's quite a different message than they'd get in our clinic.
Yeah. And just one more N of one experience is when I worked with Dr. Eric Westman at Duke's Keto Medicine Clinic. Page 4 has nothing about 12 weeks of down titration of your carbs. You get the handouts, you get the talk, and then you do it that day. You can set a date to start the diet, and that's fine, but it's not this down titration that they did in this study. So again, this study does not head-to-head compare a real life office type setting, low carb, low fat diet. So next, if wherever they got, so their goal was 20 grams of carbs or fats, wherever they ended up, they recommended and encouraged the participants to maintain that level for at least a few weeks. This is a 12-month study. Recommending that somebody stay on the intervention for a few weeks is, we'll see why they said that, because they want to stratify people by how many carbs and grams of fats they took in. But at the same time, it's again, we're going to go over the media outlets and how they talked about the conclusion to this, but just not a true low carb and low fat study. Perfect. So the second part of the dietary strategy was titrate. So once they got to their goal, they were to increase their intake of fat and carbs by 5 to 15 grams per day for periods of week at a time, with no endpoint for a specific level of fat or carbohydrate. And if satisfaction and weight loss progress were acceptable, they had the option of maintaining that level of fat or carbohydrate intake for another week, or adding back in 5 to 15 grams of carbs or fats per day. And then they should not add back any more than would be necessary to keep them at the lowest possible level over the long term, while simultaneously addressing any concerns about long-term satisfaction in terms of palatability, satiety, or enjoyment.
So can I just pause here?
Yeah.
Most people stop diets because they have cravings, or they feel hungry, or they feel deprived. And oftentimes what we'll do is we'll specifically address those things in the dietary paradigm people choose, right? If somebody, for example, wants to do intermittent fasting, we'll say, great, well, you're going to need to support that goal when you're trying to do it. So you better have water, coffee, tea, seltzer around to help sort of minimize cravings during that fasting period. That's what you've decided to do. Let's encourage you and sort of meet you where you are with your goals. Now, when somebody goes on a low carb diet, we do the same thing. How can we address your cravings in a low carb way? How can we address your feelings of deprivation in a low carb way? Right. And certainly if somebody wanted to do low fat, I would have that same sort of mindset. But what they did here was opposite. They said, well, look, you probably can't do it, so add back some carbohydrates or add back some fats. It's like, it is literally encouraging going back to a baseline diet, which we know is so hard. It's so hard to adhere to diets. And it struck me as odd that anybody would say, well, don't worry about it, just add back slowly. So I don't know if this struck you as odd, but it struck me as odd.
It did. We're going to go over their reasoning for why they said this, which again goes back to what can you conclude from this study and what you cannot. I think that this study is not as impressive in terms of finding no difference between the diet groups as the medical community would be led to believe. It's just It's the way the diet was, it's the way this study was designed, and it answered a very specific question, and it cannot be generalized to anything else. We're going to get there. All right. And then,
but it is unorthodox for a diet trial. This is not typical. I have not seen other interventional diet trials say, you know, if you can't do the diet, just go back to what you're doing and, you know, and reverse it.
Yeah, exactly. Finally, they could also consider reversing their decision and instead reduce their intake. So if you're not happy with adding back in grams of carbohydrates per day, you can decrease it if you would like, but that was as far as they got in terms of the recommendations for that. And at this point, they could maintain that level for the remainder of the study or try to add back in small amounts of fat or carbohydrates later in the study. Essentially, they're saying, yeah, you can go up, you can go down, you can stay the same. It's all good. We'll just keep measuring. Measuring how you're doing.
That strikes me as odd. You know, it's just like, you know, one of the biggest problems in any long-term study is that people generally go back to their baseline habits, right? So, you know, whether it's regression to the mean, which is a common statistical phenomenon, where as time goes on, people sort of like converge together, whether it's a lack of, you know, adherence, which is one of the biggest things in the nutrition literature, is that adherence is so important for any diet intervention. And if adherence is so important, I just could not understand why they would tell people this message. It struck me as odd when I first read it, and my suspicions were confirmed when we reevaluated KetoMed, what I think is actually going on. But continue, Dr.
Yes. So finally, inherent in this approach was the idea that the final level of fat or carbohydrate intake achieved among individuals would be substantial different among the individuals. So the central study hypothesis, this is it, Tro. This is what this study tests, and why when the media or even some of the conclusions that are drawn later from some of the authors are they're not entirely correct. The central study hypothesis was that each of the study diets would be easier for some participants and more difficult for others based on some combination of genetic and or metabolic predispositions. So I'm going to repeat that first one again. The final level of fat or carbohydrate intake achieved among individuals within both diet arms would vary substantially. That was written in to the methodology of this paper. They wanted probably, let's just say 50 people to stay at 20 grams of carbs or 20 grams of fat. They wanted the next 50 people to be at 100 grams of carbs and 100 grams of fat. They wanted the next, and so on and so forth, to just increase in their grams of carbs and fat. And they were hoping that they could correlate who adhered to the diet and who lost the most weight with what their genetics were at baseline or what their insulin resistance was at baseline. So again, to say, I'm on board with that. I think that's a really important question. If there was a certain subset of individuals that would do great on a low-fat diet because of their genetics or insulin resistance, then I'm for it. Opposite for the low-carb diet as well, I'm for that. But we're gonna again go over what the narrative was about this study when it was finished, and that is going to be almost perpendicular to what they're talking about here. Does that make sense?
Yeah. I mean, it's basically they were pushing people back to their habitual diets, you know, at least subtly, you know. And the fact that it's a 12-month trial, I mean, maintaining a diet for 12 months is very difficult. Maintaining a diet while you're being told, well, listen, just add back carbs or add back fat. I mean, it's even more challenging. So it perplexed me why anybody would do this other than to equalize the groups. But I mean, if somebody said to me, come design a trial that shows similar results at 12 months, what would you do? I would say, I would not really give people help to stick to their diets. And then I would say, well, just look, if you can't do it, it's okay. Go back to what you were doing before. You could do it slowly, and you know, whatever you can do, you can do. You know, I agree. That's exactly what I would do if I wanted to say, hey, look, no diet is different.
Exactly. And we're seeing a theme because the crossover study in keto med without a washout period, you would expect also to negate any differences between diet groups. So 2 studies in a row with the same issue. And then finally, for quality, this is pretty much standard. This is very close to keto med as well. They recommended whole real foods, many vegetables, for low carb, lean, grass-fed, pasture-raised animals, and then eliminate added sugars, refined white flour products, and trans fats. And then for the quality, for the low-fat diet, legumes, beans, fresh fruit, low-fat dairy, lean meats. And then for the healthy low carb, they should intake high-quality oils and fats, avocados, hard cheeses, nut butters, and nuts and seeds. So I'm going to summarize everything we just went over there because this is pretty much the bulk of the journal club as well until we get over to the results. They recommended to try to eat less than 20 grams of carbs or fats per day. It was acceptable to not hit this goal. Reduction could happen over months, can add back carbs or fats at any time. Both groups eliminated sugar, refined grains, and trans fats. And again, the central study hypothesis was that each of the study diets would be easier for some participants and more difficult for others based on some combination of genetic and our metabolic predispositions. This was really a dietary trial based on that investigated adherence based on their genetic and insulin resistance profiles while telling subjects to basically not adhere to the strictest definition of the diet. And then the inclusion and exclusion criteria, I have no problems with. I just put some here, but there are others if you want to read through the study. And then so their outcomes, the primary outcome for this was weight loss, various metabolic markers. And then the main thing they looked at was interaction between diet, genes, and baseline insulin secretion, which we'll talk about.
So let's just pause here because even if your stated goal is to look at the interaction between diet and genes, wouldn't you want people to be at the extremes of the diets? Like it just struck me as odd when I first reviewed this, 5 years ago. I just said, well, maybe it was just a poor clinical trial design, and maybe they didn't think this through. I now have different thoughts, but it doesn't all add up. But hit me with the baselines. I guess hit me with what did the participants look like?
Participants were similar between the groups. I have no concerns there. They had 305 people in the healthy low fat diet and 304 in the low carb diet. There's really no significant difference. The fasting insulin for each of the groups was 16. The thing that they stratified, the metric they stratified for insulin resistance was the 30-minute mean insulin after a OGTT. So kind of like a craft test, right? I don't have a conceptual idea of how high 95 micro international units per milliliter is, but generally they were similar between the groups, which is good. But that does strike me as a high insulin after an OGTT, an oral glucose tolerance test, 30 minutes afterwards. Do you have any thoughts on that, Tro?
I'm not really. I mean, I think they just, I have nothing to say other than they threw people, they thought of an idea, let's look into genes and, insulin sensitivity and let's see if there's an effect. I'm not even sure it was powered well enough to detect anything, to be honest with you, but go ahead. Let's see what happens next.
And then you have the genotypes. If you want to read more about the genotypes, you can go to the supplement. I'm not going to really spend a lot of time on that because it gets a little bit involved. Just know that they had a ton of GWAS, which are genetic studies, like observational studies that look at genes and dietary intakes, and they have some alleles or some genes that are associated with low fat intake and some that are associated with low carb intake. So for the diets, what ended up happening for these subjects? So they had 3 multiple unannounced 24-hour food recalls at each of the different points during this study. At baseline, the calories were well matched. I'm always amazed at these studies where you have these baseline intakes and then people decreased their caloric intake by 700 to 800 calories on the 3-month, like after a short interventional period. And it strikes me as not really, it doesn't strike me as physiological. I don't truly believe that these subjects were taking in 1,500 calories in each of the arms. Regardless, the calories did slowly increase at 12 months. For the carbohydrates, they were well matched at the beginning. And then at 3 months, the healthy low carb diet had 96 grams of carbohydrates, whereas the healthy low fat diet for fat had 42 grams of fat. So low carb diet, 96 grams of carbs, low fat diet, 42 grams of fat. By the end of the study, the low carb diet increased from 96 grams of carbs to 132 grams, which isn't even low carb anymore based on the Institute of Medicine's recommended daily intake. And then the low fat study increased from a fat intake of 42 grams to 57 grams of fat.
So everybody just started going back to baseline, basically.
Yeah. And I think one of the interesting things is their whole point of doing this was trying to find people who would stay at 20 grams of carbs, right? That's their whole point for trying to do this. But look at the standard deviations of these. Everybody got worse. You would expect if the groups were, you would expect the standard deviation if what they wanted to achieve actually happened to start widening out. You would have people with a mean carbohydrate intake of 132 grams, but you would have a standard deviation of 10, 20, 30, 40, because people would be higher and lower than that. It didn't happen. The standard deviation at baseline, 3 months, 6 months, and 12 months was all the same. You don't have people adhering to the data or adhering to the different diets differentially.
Yeah. So again, like if we acknowledge that we live in a quote unquote obesogenic food environment, I often say obesity is sort of like, having a gambling addiction in a casino, right? That is the way that I've sort of looked at our world. It's like, hey, there's a problem with eating, right? And we live in this environment of hyperpalatable food. I would not expect anything different, between the world that we know we live in of processed foods everywhere, and between a message where they said to, both groups, just slowly add back if you can't make it happen. And finally, the fact that they were both groups were told, drop sugar and flour. I mean, it's like they were set up to equalize the arms. There's no reason to do that. There's no good reason to do that. Mm-hmm. As a clinical trial, somebody who designs clinical trials. I can't think of any good reasons. And I've been looking at clinical trial design for 20 years. But please tell us, keep going.
Excellent. Going to the next part of their dietary intake, protein was a little bit higher in the healthy low carb diet group. Started at a baseline of 93 grams and ended at a baseline of 93 grams, about a little bit less than 10 grams difference in the healthy low fat group, which ended at 84 grams. Then finally, for the last part of their dietary intake, for their added sugars, at the end of the diet, the low fat group had 33 grams of added sugars, and the low carbohydrate group had 22 grams of added sugars, which is much more than you would obviously like on a low carb diet. That alone actually is higher than you want total grams of carbohydrates.
I mean, so at the end of this, there's literally like about a teaspoon difference of added sugar between both groups. I mean, this is an insignificant difference. Mm-hmm. It's tiny. It's a clinically insignificant difference. At 12 months, there was a literally, I don't know, like 2 teaspoon difference of added sugar. That's a joke.
Yep. And I keep going back to the fact that they wanted these standard deviations to be wide at the end of the trial. They wanted people to have all sorts of intake of added sugars or carbohydrates at 12 months. And yet the standard deviations didn't budge. They were the exact same. You have everybody increasing their carbohydrates and fat. the same, based on their recommendations. Finally, we're going to talk about this at the end because this has to do with the reanalysis. There was a big difference in the glycemic load between the diets. I think this is actually one of the biggest differences between the diets going through this table. Essentially, it was almost 41 units of glycemic load at the end of the trial, which is how they stratified these in the subgroup analysis for Dr. Adrian Sotomota's paper. So this is a waterfall plot. Most people lost weight on both diets. Not a lot more to say about this. In general, the maximum weight loss was 30 kilograms, and then some people gained 10 kilograms. So there's about a 40 kilogram range between in the groups, but there was no difference between the groups.
So, and just for the listener that's not following along with these slides, basically it looks very similar when you plot out everybody who lost weight or gained weight on each of the diets. The majority of people, looks like 80% of the people lost weight on each of the diets in a seemingly equal fashion.
Mm-hmm. Yep. So then this is the results. The average weight loss was about 6 kilograms, and everything in red on this slide is not statistically significant. So if you're just listening along, basically I would say 80% now of the results are not statistically significant. The only things that are different would be a slight improvement in BMI that honestly is not clinically relevant really for the low carb group, and the lipids were different. So HDL improved more by 2 milligrams per deciliter in the low carb group, probably not clinically significant. LDL was different by 5 milligrams per deciliter between the groups, which again, probably not clinically significant. And then triglycerides improved actually by 18, which is better. I would probably start calling that clinically significant.
Yeah, I would say these are equalized and, equalized at 12 months. So I would say there's pretty much not any difference. Maybe I would say a 1% difference.
Yep.
I wouldn't care about this. You're not drastically changing somebody's lives with those numbers.
Nope. So their conclusion, in this 12-month weight loss diet study, there was no significant difference in weight change between a healthy low-fat diet and a healthy low-carb diet, and neither genotype pattern nor baseline insulin secretion was associated with the dietary effects on weight loss. In the context of these two common weight loss diet approaches, neither of the two hypothesized predisposing factors was helpful in identifying which diet was better for whom. Thoughts on that? It's essentially we've been talking about it the entire journal club.
Look, all I can say is I think that this, you start with your thoughts and I'll sort of cap it off,
I think if you go up to the middle of this first sentence, everything after the first sentence is reasonable. But when you say in this 12-month weight loss diet study, there was no significant difference in weight change between a healthy low-fat diet versus a healthy low-carb diet, that is just putting the lead out there for media to pick it up and for either lay people or people in medicine that don't have the time to read the studies to say, well, if low fat and low carb don't have any difference, why choose one or the other? Let's go with low fat because that's what's generally recommended anyways. But the problem with that is this is like probably the 5th or 10th or 20th time I've said this in this journal club. This is not a study on low fat and low carbohydrate head-to-head studies. This tested a very specific hypothesis, which was they were trying to get people to not follow the diet. They wanted people to not follow the diet. They wanted to see if when people did follow the diet, was that if you stratified them by the genotype or their insulin resistance, could you predict who followed the diet? That first sentence, if you delete that first sentence, I'm on board with this. But with that first sentence and putting it first, I'm not a fan.
Look, we should probably, sort of bring up some issues here that I think that are probably worth noting. Okay, we should talk a little bit about the conflicts of interest of the lead author. Okay, so Christopher Gardner, who I mentioned, he is served on the nutrition committee at the AHA. He has served on scientific advisory boards for the Culinary Institute of America, which is very much pro sort of plant. He has written for Civil Eats, which again is very pro sort of plant. He has been on the board of directors of the True Health Initiative, which is actually David Katz, who's also heads that up, has been known to bully people who support meat and meat consumption in their research. You know, when their research is supportive of this, there's Freedom of Information Act emails showing that David Katz has literally bullied researchers and tried to get their research discredited. So this is the, Krista Gardner is also an advisor for Diet ID, along with Walter Willett, who's had a similar sort of behavior pattern in terms of academic bullying. So this is the people that are doing the study that are literally designed perfectly to equalize arms.
Yep.
Designed perfectly to equalize arms. So that's my sort of input on that.
Agreed. And then, so of course, what happens is the media runs with this, and I specifically searched for exactly within the 2 to 3 month time period of when this was published, and essentially the best diet for weight loss, your choice, low carb or low fat. And then Stanford Medicine, which is where Stephen Gardner is, low carb or low fat, raw study finds low fat diet versus low carb, and the winner is which diet is best for long-term weight loss. I'll give you a hint. That Harvard Health article said that there was no difference. Low carb versus low fat diet study, eat more veggies, less sugar. And then the key to weight loss is diet quality, not quantity, a new study finds. So this is what I have the biggest problem with. That's not what this study showed. That's not what this study investigated. That's not what their primary hypothesis was. This wasn't even a low fat versus low carb head-to-head study. It is what it is at this point because it's 5 years old. But this is one of the more frustrating things to me in research nowadays is.
But let's go back. A lot of times people may think that, this is just the media getting it wrong, right? But the media literally reaches out to scientists and says, how should we interpret this, right? And so, it's clear there's a pattern of behavior here. Keto Med was literally one of the most biased studies I've ever seen in nutrition, like literally designed to be biased, right? And so if you look at this, you see that pattern of behavior 5 years prior, right? And then, you see sort of the conflicts of interest, and you see the, you learn a little bit about who they buddy with, like David Katz, Walter Willett, and the boards that they sit on. And it just strikes me as so very clear the study was designed to have the outcomes it did. And in fact, I got to be honest, some of the blame should go to Peter Attia, who was the only physician, right, at NUSI, right? How did he not catch this? How did he not catch this? So there's my thoughts, and I'm going to get in trouble for that one, but it is what it is.
Moving on, and actually great segue into what this study did actually right. So it had a very large N, and for better or worse, exactly like what you just said, this was in their supplement, and you can also look at it on the clinicaltrials.gov. And I'll read a little bit off this slide. In their supplement, they said they were approached by NUSI in the fall of 2012 after getting the first round of funding from the NIH, and they offered $3 million, which is a lot of money in any nutritional kind of intervention, with unrestricted funds if they could also raise a matching $2 million. So they could increase their budget for this study by $5 million. And this allowed them to increase the sample size from 400 to 600 people. It allowed more inclusion criteria, and then it allowed them to measure the insulin resistance, essentially with the Kraft test, insulin at 30 minutes after an OGTT. And that's that. There was, at the end of the study, a difference actually in carbohydrate and fat intake. It is not what I would call either a low fat or a low carb diet, though, but there was a difference. And then finally, they were able to test their hypothesis that there was or was not an interaction between diet and genes or diet and insulin resistance, of which there was no interaction. So I think, again, that first bullet point is probably now the 25th time I've said this in this study. You can only make conclusions from what is tested. We can beat that one again. And then finally, interestingly enough, they have measured ApoB and LDLP in this study, and but it was not reported. So you can see the appendix where they measured all of their data, which is also interesting. We know from Virta Health that there's no change in ApoB between a low carb diet and a control diet. So, maybe they just forgot, or they just didn't want to make another line on their results page. But imagine if the LDLC was different, which it was, but the ApoB was not. If you purposely withhold that information, what are you going to do?
Well, apparently it's all on Open Science Framework. So if there's a researcher out there listening to this, they can go to Open Science Framework, and look at the data, and hopefully it's there. I wouldn't be surprised if it is there. Mm-hmm. Given that, I suspect there'd be minimal discordance, to be honest with you.
Yeah. And then funny enough, the change in the LDLC between a low carb and a low fat diet in this study was on the order of the side effect of an SGLT2 inhibitor, which is about 5 to 7 milligrams per deciliter. But I think the biggest thing we can spend the rest of our time with discussing is so
the listener doesn't get, this is Dr. Calkins being very cheeky, right? Okay, so if you know anything about medicine, he's being very cheeky. So yeah, thank you for So bottom line, it's an insignificant difference.
Exactly. For the listener, SGLT2 inhibitors are these new classes of medications for diabetes, and they've shown pretty good cardiovascular and kidney disease outcomes, but they do have the pesky side effect of raising your LDLC. And finally, the reanalysis of this paper. So I'll go through these next three slides, and then hopefully, Tro, you can add some information, because I'm not the world's expert in these type of statistics, but I know you recently had a podcast with Dr. Adrian Sotomoto. So speaking of, he was the first author. The primary PI was Dr. David Ludwig, and this was published just last year, and it was a reanalysis of the DIETFITS trial looking for evidence for the carbohydrate insulin model. And you may be able to talk a little bit more intelligently about that than I will. This is essentially the thesis of the entire reanalysis, this one graph. So they basically looked at people who did lose weight with glycemic load reduction and their baseline insulin, and they've found that, as predicted by the carbohydrate insulin model of obesity, weight loss in both diet groups of DIETFITS seems to have been driven by the reduction of glycemic load more so than dietary fat or calories, an effect that may be most pronounced among those with high insulin secretion. These findings should be interpreted cautiously in the view of the exploratory nature of this study, meaning it was a post hoc, meaning it was done after the study, and you can't register this kind of reanalysis. So there's probably needs to be another study done on this specifically. But that is all I have, Tro. I'll let you take away the rest.
No, you can leave this graph up. So what happened was, and I'm gonna sort of summarize, and I highly encourage you to go listen to the podcast with Dr. Adrian Sotomoto, who really summarizes this well. But what they did was, what actually happened is NUSI and the NIH asked that their researchers post the data on the Open Science Framework, which is sort of like a open source data repository. And so what they did was they posted it all there, And whether they knew or didn't know, this gave the opportunity for other people to go and reevaluate that data to see, well, did the researchers miss something? Did they look at it differently? Is there something that they may have missed, or some idea that they have missed? And, one of the issues they saw was that there was a lot of dropouts. And when, imagine somebody stops coming at 9 months and you have a 6-month weigh-in. Well, what happens if you just took their 6-month data and plotted out to 12 months and added them back in, right? What happens if you just sort of imputed the data, right? Rather than dropping them out, right? And when they did that, all of a sudden there was that's called the lasso model, right? Using lasso with linear regression. It's a fancy way of saying, let's put in some values, right? Let's put in some values that we suspect would be there with these dropouts. So what they found was when they did that there was actually statistically significant difference. There was a difference at 3 months with weight loss, low carb did better. At 6 months, low carb did better. And when you took the dropouts between 6 to 12 months, which is going to happen, right? And you just imputed that data at 12 months, low carb did better again. Next, what they did was, again, this is beyond my expertise. They took sort of several different possible variables to see what correlated most with weight loss. And this graph actually does a really good justice to it. What was it that had the strongest correlation with weight loss? Was it in both arms? Was it the added sugar? Was it total carbohydrates? Was it saturated fat? Was it the calories, fiber? What had a very, very strong effect on weight loss? And out of all those, 8 things that they looked at, the biggest effect on weight loss was the glycemic load. And in fact, it didn't matter, whether you ate fat or not, right? Whether you ate fat or not, it didn't have a huge impact, right? So just think about this means, right? And this is consistent with other meta-analysis that have compared low carb and low fat diet trials. When they go back and say, I don't care what diet arm it is, what are the things that predict weight loss? It's not the calories they eat or the calories they measure they're eating. It's not that. Just like you pointed out in that DIETFITS study, those calories are not accurate, right? And what do we find in these meta-analysis? And what did we find with this reanalysis of DIETFITS? Calories didn't matter, right? They didn't matter, right? I'm not saying from an energy standpoint, they don't matter. However we're measuring it, it doesn't matter. It doesn't predict weight loss, right? But you could predict, and the fat in the meta-analysis, large meta-analysis of low carb and low fat diet trials, fat intake, the more fat you eat, actually, the more weight loss you actually get. And this is of low fat and low carb trials, right? So, and what did they find here, in the reanalysis of DIETFITS? It's basically neutral. Fat did not predict weight loss. But what they found was the glycemic load predicted weight loss, and to a high degree, meaning like the higher the glycemic load, the less weight loss. The lower the glycemic load, the more weight loss. And it was strikingly different. So what does this mean? It means when they look back at the data and said, what predicts weight loss across the whole trial, right? Across everybody, okay? In a trial where everybody was told to drop sugar and drop flour, what predicts it? It's not the fat intake. It's not the calories. It's not how much fiber they had. Right? It's not the calories. If I said that already, it's the glycemic load, right? It's the glycemic load predicts weight loss better than these other things. Now, that's not saying that calories don't matter, fiber doesn't matter, fat doesn't matter. I'm not saying that, okay? What it showed was glycemic load literally predicts this. And when you stratify it by insulin, it was even more apparent, right? It was even more apparent. So this was, sorry for my this is, I'm not a brilliant statistician. Okay. I'm just sort of a guy who wants to know what to do best for the patients in front of him. Mm-hmm. And what this tells me is, this is more support for the carbohydrate insulin model. Now, here's the thing. This is all sort of retrospective review. So like, just for the listener, what's actually going on here is there's a bunch of researchers who are highly biased, whether implicit or explicit. I think it's explicit. Okay. And they're presenting data through their lens. And now what's happening is you have people who are in favor of a different model, right? Reevaluating it within their lens. So, I view this as like, I'm the middle child, right? I see, mom and dad fighting, right? At my heart of hearts, what do I want? I want the best possible information for my patients. Mm-hmm. And I walk away saying that, hey, look, there's a lot more to the carbohydrate insulin model than meets the eye, right? And, ultimately, whatever, we have to help the people in front of us, and lowering their carbs, lowering their sugar, not only is it measurable, it has a very clear impact. That's the way I interpret all this. So I don't know, do you see it any differently than I do? I mean, that's my reinterpretation.
You're exactly right. It's all about the patient. I think I think there is I don't want to call it a disconnect, but you can call it a disconnect between researching and what we see in the clinic. And we're taught fairly. Yeah, we're taught fairly aggressively in our education that you have to rely on the evidence-based medicine theory that exists out there, and the things you see with your own eyes, it doesn't really matter if there's not the randomized controlled trial for it. But we know Atkins was basically helping people with their metabolic disease way before even the conversation of the energy balance model or the carbohydrate insulin model was created. It's an important discussion because it can lead to more therapeutics and lead to better guidelines and lead to more adoption by more physicians. But at the end of the day, I really care about what is going to help my patient not have that diabetic foot amputation in 10 years. What's going to help them get their A1C to below 5.7 and off of all insulin. And I think we have the real world data. We had Atkins, then we had Westman. Now we have Unwin and yourself, Tro, of real life office-based interventions, pragmatic interventions that blow this. Even on this graph, the best weight loss here, the average weight loss in this study was even 6 kilograms. What we do in the clinic day to day over the course of even a full year.
About 3 times that. So yeah. Effect is about 3 times what they're getting. Now, look at it from their standpoint. Their standpoint, they'll say, well, maybe just Tro and Matt and Dr. Laura and Brian Wiley and, Amy Igus and Alice, Smith, maybe they're just like the most compelling people in the world. And maybe they're so charismatic, right, that they just help their patients adhere. Whatever the reason is, like you're measuring, they are measuring regression to the mean. We're measuring actually getting people to do what their intentions are, what their goals are, right? And so there's a huge divide, but this trial was specifically designed to equalize results. Mm-hmm. It was specifically designed to take out all the qualities known to sort of benefit low carb, and just sort of push people into they're back to their baseline habits, which is the exact opposite of the message for the last 20 years. If you talk to any doctor, they say, what's the most important thing in weight loss? And diet, it's adherence, right? This is like the mantra, right? So why didn't they help these patients adhere to each of their diets, low carb and low fat? And it struck me as odd. And I reached out to Gardner. In fact, in 2019, I talked to him about it. And he said, yeah. Well, we just wanted people to know, do what they could. Right. And, I sort of said, okay, maybe. Right. I said, okay, maybe. Right. Okay, maybe. And then KetoMed comes out and I'm like, this mother effort, this mother effort. So
this was a nudge. KetoMed is a gut punch. KetoMed is it's indefensible to me, but it is what it is. Even the use of their language in the conclusion for KetoMed was biased.
Right. And, this is Matt. So this is the thing, right? Look, what does this show? It shows that we really, at the least, we need to push people to, the extremes of diet if that's their goal, right? If a patient's goal is I want to reverse diabetes, reverse metabolic syndrome, right, and I want to do it with a low carb or intermittent fasting lifestyle, we have to push people to their goal. Mm-hmm. That's what I take from this, and what's the other thing to take? Dietary adherence is important, right? If adherence is what matters, right, and adherence is what predicts weight loss, we should be fighting to help each patient adhere. How can we make this easy for them? It needs to be our mantra. And lastly, the thing I'll take from this is there's so much bias in medicine and there's so much bias in nutrition, and whether it's implicit or explicit bias, I didn't know after DIETFITS, but I know now after KetoMed, it's explicit bias, right? But, that doesn't mean that we're free of bias either.
Right.
Right? That doesn't mean we're free of bias either. Just because we point out their bias doesn't mean we don't have our own blinders. Mm-hmm. So that's, when we reanalyze the data with our blinders, it's clear that there's a story that glycemic load and glycemic load matters in people with metabolic syndrome. Mm-hmm. You can wrap us, so you can give us the last comments here.
Yeah, I think you hit the nail on the head. Even with the reanalysis, this last sentence tells the tale of the tape, which is these findings should be interpreted cautiously. I just wish that could be the going mantra of most people in nutrition science.
Yeah, I mean, look, bottom line is, I think you're right. I think people listening here, we have to change medicine, right? We have to show our results in clinic and we have to publish our results, aggregate our results, study our results, because that's the only way we're going to make a dent in how we do things. I no longer believe we can change our big organizations. I think we just have to demonstrate that our approach works and works more powerfully. That's all we can do. There's nothing else we can do. I've stopped trying to change the AFP, the AMA, the CDC, the FDA. I'm not going to be able to change those people, but I can change patients' lives and I can show those people what we do. And hopefully, Dr. Matt, you'll be joining us soon here in that mission. We're proud to have Dr. Laura here with us.
Looking forward to it.
All right, guys, have a good one. Thanks to everybody for joining us. Thank you, Patreon supporters. Thanks for the people on the Dr. Tro app for joining with us this morning. Guys, have a good one.
Thank you, everybody.